All right, well, good evening, everyone, and thank you for joining us tonight in what's going to be a series of webinars that the Australian Institute of Paramedic Practitioners is going to put on for all our members and guests. Tonight's webinar is going to be with Luke Giles, who's our International Board Director, and he's going to be talking about the use and introduction of paramedic practitioners over there in the UK. Luke's an active paramedic practitioner in the UK. And it's a great little interview that we've had together, just covering off on how it was introduced, how we got into it, and some of the challenges and some of the really awesome ways in which it's really kicking goals over there. So what we're going to do is we're going to play a live recording of that interview. It goes for about 30 minutes. And then at the end of it, Luke's going to join us for a live Q&A. So while you're watching tonight's webinar, please take down as many notes or questions that you might have, and then Luke and I will join you for the live Q&A at the end of tonight's webinar. So thank you again for participating. We value the support of both our members and guests that come along and we put on these webinars for free. We value CPD, and we're looking forward to bringing some of the others in this similar format throughout the year. All right, so without further ado, I'm going to start the webinar, and then at the end of it, we'll kick into the Q&A. Yeah, there we go. Right, there we go. Here we go. Now share. I'm going to share the sound. All right, so here we go. And once again, welcome to our February CPD for the Australian Institute of Paramedic Practitioners. Welcome, Luke.
Thank you, Duncan.
Welcome to this CPD webinar that we're putting through today. And also for our membership, you're also one of our international board directors for the Australian Institute of Paramedic Practitioners. So welcome to that role as well.
Appreciate it. Thank you for having me.
And also thank you for putting a little bit into our newsletter for 2025 as well. It was a nice way to finish off the first newsletter for the year.
Yeah, absolutely. And I think it's really interesting, particularly if you're based in Australia, to get some insights to how things are run in different parts of the world, and maybe some kind of advancements in the paramedic profession that haven't quite hit Australia. So I think, yeah, having a little bit in the newsletter and this video specifically are going to be good to kind of give a little bit of an extra view to where things could be and where things can go.
Awesome. So just so everyone knows, what we've done is we've pre-recorded this interview that I'm doing with Luke today. Feel free to take down lots of notes while you're watching it. And then what we're going to have at the end of it, well, at the end of when you've finished watched it, Luke and I will be there live, and you'll be able to ask Luke as many questions as you have relating to what we discussed today.
Yeah. Hopefully I can answer them.
Unreal. Cool. So, Luke, what led you into the field of paramedicine?
It's a good question. I think we all kind of get asked that a lot, don't we? So I'm going to be 100% honest. I had a thought about what I wanted to do when I was probably 2 months from finishing high school, and I thought I would love to be in the fire brigade. So I was like, what can I do to make sure I get in the fire brigade? Well, they like when you have a degree. A degree in paramedicine sounds pretty interesting. And I remember being in my first few weeks, I never did like biology or anything like that in high school. And I remember my first few weeks of uni, I absolutely fell in love with it. I was like, this is super interesting. And I wasn't sure what to expect. And ever since, it's definitely been, something that to this day is constantly educating me. It's been great. And I think that, you kind of get a really good balance, don't you, depending on what you do with not only learning about specific sciences, but also being active, and obviously, all the classic things like helping people and providing care in emergency situations. it is actually fulfilling as much as it sometimes when you've been in the field for a long time, I think you kind of maybe get a bit desensitized to, how fulfilling and the role actually can be.
Yeah, what drew you there in the first place?
Yeah, exactly.
Awesome.
But for me, I mean, yeah. So as soon as I started doing that, I fell in love with it, and it's been working ever since for the last. That would have been 14, 15 years ago now.
I bet that's blown.
Yeah, absolutely.
So, obviously, with your accent, it's fairly similar to mine. You probably weren't born in the UK. So,
Correct.
what drew you to the UK? Because that's where you're currently based.
Yeah, another good question. Although some of my Australian family members might disagree with you, they think I have a bit of an English twang these days after spending, close to a decade here. But I think it was a similar pathway to what most people ended up having with London Ambulance coming to, our final year universities and asking if we would like to come and work there. And I thought, that sounds pretty interesting. I'd never been to London. I'd never been to any of Europe. I didn't know anyone here or have any family here, no like cultural ties, but I was like, I might as well, check this place out and see what's going on. And I told my family I would be leaving for 2 years. And yeah, that was in 2016. So they're still trying to get me back to Oz. It's a great place to be. I love London. I'll still
it's
say
super
that
central, isn't it? Like a weekend over in Europe, 8-hour flight, you're in Canada or the US. Super central.
Yeah. A couple of years ago, I jumped in a car and drove to Luxembourg to see Flume. It took about 5 hours, and we passed through, 4 countries. So it's a unique experience to Australians, I think.
Oh, if you'd driven 5 hours in Queensland, you wouldn't have even left the state.
Yeah. And that people here have a bit of a hard time comprehending that as well, I think. It's kind of the reverse.
Yeah, unreal. Cool. So, what drew you to sort of the paramedic practitioner role in the UK?
Yeah. So before I started the rotational practitioner role, I was in something called tactical response in London for about 3 to 4 years. And that's like the kind of the stabbings and firearm unit that go around as solo responders in London. And I felt extremely confident with my job. And I saw this come up and I thought it might be an interesting kind of change of pace. So I started with the rotational role and was the first London Ambulance paramedic to get into the Greenwich course, which was called the First Contact Practitioners course. And it's been not at all what I expected. It's been significantly more challenging and significantly more rewarding in kind of ways I think we'll get into in a bit. But what drew me to it, I think, was just probably what drew me to London, just to see what it was like. I guess you never really stuck somewhere, so giving something new a go hasn't been a detriment to me yet.
That leap of faith approach.
Yeah, I think so. And you can always reverse things if it doesn't work out, but so far so good.
Yeah, unreal. Cool. So yeah, that does lead us on to our next question. Is like, as one of the first people from London Ambulance Service to go through that Paramedic Practitioner Greenwich course, what has that journey sort of looked like for you from when you finished the course, or sort of going through the course, and obviously your placements, to then graduating, and then sort of getting to the point where you are now? What does that journey sort of look like, and how has it evolved?
Much more challenging than I expected. And so not only, was I one of the first in the course, but I was also the first ever paramedic to come and work in my current PCN, which is a combination of 4 different GP practices. So my first few weeks were lots of discussions with GPs, with them saying, why are you here? What can you provide to us? And I've kind of had to figure that out for myself along the way as well. And, I said that I went in as quite a confident practitioner. And I remember, I think I've said this to you before, Duncan, but my first day working in primary care, I had someone with abdominal pain and did quite what I thought was quite a thorough assessment, and he'd left, and I went to talk to my mentor at the time about it, and he asked if I'd done a H. pylori and a fecal calprotectin and a fit test. And I said, I don't know what any of those things are, so I don't think I have done them. So I think the learning curve is certainly the first challenge that you come across. And I mean, primary care is exposure to every single different specialty of medicine. You know, you might get a letter from a rheumatologist. You might have a conversation to a cardiologist. I mean, there's kind of no parts of medicine that don't eventually get involved in primary care. And I mean, primary care see the vast majority amount of NHS appointments on a yearly basis. So it's very busy and very varied. And that is a massive challenge. And I think it's really easy for us, especially the course that I was on. You had to have already been, you know, a fully qualified paramedic for at least 5 or 6 years, I think it was. So you go in as quite a confident practitioner, and that initial, I would say probably 2 years at least of a very, very steep learning curve, can throw you at times. You need to kind of remind yourself that, you know, you're here to try your best to do a good job, and kind of take hold of that, the kind of self-education, the CPD. And I mean, I listen to a lot of primary care podcasts and do a lot of Southwest London training events. And I think that it's pretty easy to have some imposter syndrome at first. And the balance between trying to be an independent practitioner, which we're all very used to doing, and knowing where your kind of knowledge limits are, which will change over time, is really, really probably the most important thing. And having someone who is a mentor to my mentors are all GPs. I have one specific listed mentor that I have some educational sessions with every week, and going to them and even just running something by them when you already have a plan, I think is kind of at the stage that I'm at now, if there's any uncertainty. And I think that's a really, really important thing for not only your own learning experience, but also for patient safety. And the more that you come across really challenging things where you're at a bit of an impasse and you get a bit of guidance, or see something that you've never seen before, that's how you build yourself as a clinician, and you kind of start to progress.
Yeah, no, really interesting. Yeah, and so
sorry, went on a bit of a tangent there, but
no, that's okay.
I think the main challenges are there's a lot of things that we don't get exposed to, and people aren't used to you being here, and so.
Did you get that sort of, oh, you're not the doctor? Did you ever get any of that when you? Yeah.
You know what? Sometimes I do still, but there's a massive amount of respect for paramedics in the UK and Australia and Canada and all those sort of countries. And I think it's really important just to define your role and tell people, you know, sometimes someone will come to me with a question that I might not know, which is also happens to GPs and other medical professionals. And then we might have a multidisciplinary team meeting about that person. I can say that I'll get back to them. Primary care is a little bit of a different pace. Sometimes you don't need to maybe know the answer on the spot. We have something in the UK called advice and guidance, where we'll be able to send a message to a specialist, and they usually get back to us within the week, and suggest some other treatments or tests, or they might want to see them in their clinic. And so saying I'm not sure or I don't know, but I'll get back to you about that is another really important thing to know, which I don't know if I did too much as a paramedic. You know, you don't often say, I don't know how to treat this, stab wound in your leg. You're pretty on top of those things.
Let me get back to you on that. Just hold that thought for a moment. Don't bleed too much. Yeah.
I'll advise and guidance your leg wound.
Unreal. Cool. So, so do you think probably it was about? So how long have you been in this role, the particular role you're in now? How long now?
About 3.5 years.
So you think it was about that 2-year mark you started to feel a bit more comfortable?
Yeah. I think it takes a while. I think it takes a while. Not only the thing, trying to learn the things that you're not exposed to, but just getting used to that, what I just talked about, getting used to the fact that you're not going to know a lot of the answers. People are going to come to you in primary care with a question that you never would have expected them to ask, or something that you've never heard of before, or quite a niche, rare medical condition that obviously you're not going to be all over. And that's kind of support network of having a GP who's on call, who you can go and talk to, having a mentor who you can discuss the case with later, having a specialist team that you can advise and guidance with and do referrals to, are all kind of support networks around you. They're really important to lean on when you have uncertainty.
So you do get that opportunity to be able to sort of do some case debriefings with your mentors and go through areas and other aspects like that?
Yeah. So that happens for me. It's a 2-hour session on a Thursday once a week with my actual listed mentor. And then if there's any questions at the time, each of my GP practices have a specific named GP who's on call, who will deal with medication requests or emergency appointments. And if I have uncertainty about the condition or the medication that I'm prescribing, I run it by them. And normally it's quite a brief conversation, but everyone in my current PCN is ridiculously helpful, and yeah, I think that it really makes a huge difference.
Yeah, that's really cool. Before we move into sort of what your typical day looks like, talk to me about what it was like sort of going through the introduction of prescribing into your role. Sort of what did that look like?
Yeah, I think that's a very similar experience to coming into primary care for the first time, kind of that description of that steep learning curve. You've been in it for a little bit, you're feeling like you're seeing more of the common conditions and know how to treat them. And then all of a sudden you get thrown into prescribing, and it's much more complex than I would have expected. The guidance here on the BNF, which is what we use to kind of use to guide our prescribing in the UK, for an independent prescriber, is that you can prescribe any medication within your comfort zone or knowledge zone and capacity, which is super, super broad. Yeah, exactly. But it also makes sense because some people who are ACPs, they might work in a cardiac ward, or they might work in a hospice, and the types of medications they're going to be prescribing will be significantly different to the typical types of medications that I prescribe. There's obvious ones, antibiotics are pretty obvious. Things like acyclovir or analgesia or antihypertensives. But then when it comes to some of the more complex ones that need monitoring, there's quite a few medications that I'll prescribe that I know I need to do a liver function test before and 3 months after, or think about what sort of bloods I need to look at. And it becomes this whole complex picture to look at, and very, very often, especially with polypharmacy and elderly populations, when you're considering a new medication, there might be a drug interaction with their old medication, or that it might have an effect on their renal function, but their renal function is borderline, and there's really a lot of considerations, and sometimes no 100% clear answer either. It's often a cost and benefit analysis. And again, that was the same sort of thing, when I was prescribing potentially something very basic like cocodamol or amoxicillin for the first time. I would run it by my on-call GP and be like, I'm thinking of prescribing this, here's the indications, and we would have a brief discussion about that. And now I'm finding that I'm pretty confident in doing those things, but some more complicated medication, I'm still able to have that support network to run past. So I would say pretty tricky. It's pretty tricky, but it's doable, and if you kind of take hold of your own learning and you love your job and you're kind of passionate about it, I think having that continuous growth will be really good for you in the long term. Because if you're not kind of educating yourself and taking onus, it's going to be really difficult you're going to have that learning curve be steep for quite a while.
Yeah, no, 100%. No, that's great. Great analogy. No, thanks for that. Yeah, I think there's a bit of misconception there by, you just go to a course and it's all good and here's a list of things you can have access to, whereas, hang on, no, there's a little bit more than that. So, yeah, no, that was a
Yeah.
great way to describe exactly the type of approaches with that. So, yeah, cool. So, with that in mind, what does a typical day for you look like in your current role? Because obviously you're not sort of signing on before shift, checking out your drugs, jumping in a car and chuffing off to the next primary healthcare job in an ambulance. Like, what in
Correct.
your situation, what does that look like, a typical day?
Yeah, so that's a good question. And I've worked in 6 different GP practices now, and they all have run it slightly differently. And so when I came to this surgery, I think there was a really good bit of collaboration between, my managers and my mentor, saying, what we haven't had a paramedic before, what might work for you, and my kind of previous experience in what didn't work.
Mm-hmm.
So at the moment, my typical day looks like, in the morning, I'll have usually 8 phone calls that are triage phone calls.
Mm-hmm.
So I'll call them, have a brief discussion, decide if they need to come in person or not, if we can sort their issues out over the phone, which I think as a kind of a paramedic practitioner, potentially I have less confidence to do than a general practitioner. I see often everyone works in their kind of individual ways, but we're very used to getting obs on and seeing people in person and being very hands-on as paramedics.
Mm-hmm.
And I think that's
Yep.
stuck with me a little bit. And I think people appreciate it as well. But it's not always necessary, but so triage calls in the morning and then face-to-faces for my later morning. Today I am having something called a PACT review. So it's an elderly, vulnerable patient, and we do kind of a holistic review of their overall health once a year, to kind of be a bit proactive, see if there's any support that they need, or deteriorations of any aspect of their health, including like vision and hearing or mental health. We go over kind of a wide range of things. My afternoon will be 2 or 3 house visits. One of those will normally be pre-booked, and then the other 2 will typically be things on the day. So, if someone who is housebound is having difficulty breathing, but it's been going on for a few weeks and they're speaking full sentence over the phone, it's not necessarily indicated to call them an ambulance, but it definitely seems like they need to be reviewed because they're quite vulnerable. Then I'll go on something called a rapid response. So the other 2 house visits are typically rapid response. And then I'll typically come back to maybe 4 face-to-face. I've got a child clinic in my late afternoon to end of the day.
Mm-hmm.
That's kind of what a typical day looks like. Although at my other practice, for what my mornings once a month, I'll do something called triage. So the way they book appointments now is everyone sends in a contact form, kind of describing their problem, and it gets triaged by myself and a duty GP. And we are able to signpost them to various resources. For example, yesterday I was on triage, and someone sent in a contact letter saying that she potentially has thrush. And we signposted her to something called a sexual health clinic, where they have a walk-in center. They have more extensive testing and they can give treatment at the time, and they do follow-ups, and they're a really good resource to have in the community. So she was signposted there, and I think over 50% of our contact forms don't end in an appointment. So half of them don't end in an appointment, and a lot of them are, I need this repeat medication, or a very brief conversation about maybe some chronic pain where they use something PRN and they would like another lot of cocodamol or naproxen or whatever the medication is, or potentially they have a UTI and we just advise them to bring in a sample and we can dip it. So triage is another thing that I do as well. In terms of the actual patients that I'm seeing, is a really good question. It's very diverse. It can be pretty much anything, sometimes it won't be the thing that they've initially called up with, which is, you know, we've all experienced healthcare before. It can be quite typical sometimes. So a lot of, because it's cold at the moment, there's a lot of respiratory infections, a lot of tonsillitis.
Yep.
There's a neurovirus going around at the moment, so a lot of DNV. And then I'm seeing someone today and doing some hypertension bloods because they have a new raised blood pressure, and we've just done a diary for a week. There's a few people booked into me today with ear infections, one with some MSK issues. It's
super varied.
It's wide ranging.
Yeah. So in that sense, it's not that dissimilar to like some of the calls you would have seen when you're running around in a normal ambulance or a rapid response car. Anyhow, like you never really know what your day is going to look like.
Exactly.
Yeah, and just going back to those rapid calls, some of those rapid calls sometimes end up with an LAS ambulance then coming out to transport them, or can a lot of them be managed at home?
It's a good question. I would say, if I had to take a guess at it, probably 95% can stay at home.
Yeah, cool.
Very rarely do they have to go into the hospital. Sometimes I'll do a follow-up call like the next day or the day after if their observations are quite borderline. And I'm concerned about them. Sometimes, obviously, sometimes people need an ambulance and it's necessary.
100%. Yep.
But I think the kind of the way that paramedics add to this really, really well is pretty much our whole careers we've had to make a decision whether someone needs to go into hospital or not. And we're able to identify, you know, what a hospital actually might provide. What interventions are they going to do for this person? Are they going to do anything that's different to what we're able to do in the community? And if that's a yes, then they need to go in. But more often than not, it's a no.
So given your bigger scope in this role, it's the no. You're able to value add to keep them somewhere where they belong, as opposed to somewhere they don't belong. So cool.
Yeah, and meeting. So I met with one of the authors of the initial role description last week, and his intention for originally creating the role was primarily to be a rapid response team and kind of make that decision on whether people need to go into hospital or not. Because when you don't deal with emergency situations all the time, it can be hard to tell.
Sure.
Sometimes it's tricky. Sometimes people get sent in unnecessarily, and sometimes people can be managed at home. And I mean, I had a patient last week who really didn't want to go in, and we had a conversation for about 50 minutes, and she ended up going in. It was really important. She probably had enough. She'd be sitting on her couch for 3 days, and I think over your
poor thing.
Yeah. It was very, very clear that hospital was necessary for her, but she was determined with capacity, and that over the course of careers we really develop skills in convincing patients that this is the best thing for them and why, even when they're very adamant that it's not necessary. So I think it's a bit of an underrated skill in our profession, really, is kind of having that conversation, still being on that patient's side, but convincing them that, you know, if you can't walk at the moment, you're quite vulnerable, and you might
just a flesh wound,
fractured your hip. Yeah, I mean, she's a tough old girl. I respect her.
I can crawl around on the ground. I'm fine. I'll be able to walk in a couple of days.
Far off what she was
saying,
my
goodness.
Bless her. Yeah. I mean, we've seen it all before, haven't we?
Yes. So, on that, where do you see the role potentially going in the UK? Because obviously it's much more mature in the UK than anywhere else in the world. And where do you potentially see it going internationally as well?
Yeah. I think it's funny that it's much more mature in the UK, because it still feels really fresh in the UK. You know, people are often surprised that there's paramedics working in primary care. People, GPs are still not 100% all over if they haven't worked with one before, what it is that we actually will be doing here. So I think that in terms of how it's going to grow in the UK, you know, it's working really well at the moment in my experience, in my colleagues and patient feedback experience. I'm obviously not in other primary care networks. I've been in another one, but I'm not in all the others around the UK, so I'm not sure how it's going there. But here it's going really well. So I think how it will evolve will be, it'll become a common element of primary care. I think that it's not going to be surprising when, you know, you need a medication review and you're being seen by the lead pharmacist, or you need travel vaccinations and you're being seen by a travel vaccination nurse, or you come in with an acute respiratory illness and you're being seen by a paramedic. I think that's going to become more and more normal. How will it evolve in Australia? I think that it'll get to the point that we're at now, probably quite soon. Especially, there's been quite a few studies saying that it's effective and it's safe and it's cost effective under certain stipulations, which we've gone over before. You know, having those support networks around you at all time
100%
is kind of, it's really, really important. And I don't think it would be possible to kind of run this kind of novel role safely without having those in place and kind of knowing when to fall back on those. But I can definitely, I think it's inevitable that Australia will end up with paramedics in primary care.
And I think you hit a pretty valid point there, because paramedics are pretty risk-averse group of practitioners in the first place, and they're not afraid to consult or ask for help if they need it. And one thing services have done quite well around the world is introducing that sort of telemedicine level of consult if you're either on your own or you're in a pair and you're going, let's ask someone with a little bit more knowledge than us, because at the end of the day, we're all humans. We don't know everything.
Exactly.
And I think because we're in that sort of risk averse, we're used to consulting with others. I like your analogy in that having that support team in that role, because again, we're not an island. Like, it's collaborative healthcare, and collaborative healthcare we know works.
Absolutely, 100%. And, you know, we're not the only ones who do it. GPs constantly call people. I mean, we've got something called a hot clinic at St. George's for pediatrics. They've got a pediatric consultant on call. If you have concerns about a child that you've just seen, you can call them and they'll talk to you within the space of 15 seconds. They're going to answer the phone and they're going to say, yeah, bring him into the hot clinic, or, you know, maybe do some safety netting or give you some advice on kind of that higher level of speciality. And that goes for the same for nearly every you know, clinical speciality in the UK. I can talk to a urologist, I can talk to a cardiologist, and the GPs have these resources available to them, which is super helpful. And we have, as paramedics, the GPs and then that as well. So yeah, it's really, really cool. Important.
Yeah. Look, I remember going back in 2018, I did a retrieval in Mongolia, about an hour and a half south of the Russian border, and ultrasounded someone. And I looked at the ultrasound and going, I've never seen an ultrasound like this. And I ended up speaking with someone in the US, radiographer in the US, who then talked me through what it was. And yeah, so I mean, it's amazing to be able to do that within the profession. To say, hey, I'm not quite sure what this is. Let's phone someone up and ask.
Absolutely.
Yeah.
Unthinkable 30 years ago.
Oh, 100% unthinkable. Oh, yeah. You are the bearer of all knowledge. You know everything. Yeah. Where now it's
absolutely.
like, actually, I don't really. Let's phone a friend.
Yeah. I think one more thing to add as well is, you know, you talked about where this is going to evolve from here. If you go into a hospital, you know, there is a team of people with various professions and kind of knowledge bases reporting to normally the senior consultant, and who will make the decisions or run something by them. And that's how I'm seeing primary care transform in the UK. You know, we have physiotherapists, we have pharmacists, we have something called social prescribing. We have quite a few different disciplines who report back to the on-call if needed. But I think we're going to see kind of a transformation from primary care being it's only staffed by GPs to it's staffed by a multidisciplinary team under kind of the guide of the lead GP of the day.
Yeah, excellent. That's really cool. Looking forward to sort of seeing that. So before we sort of wrap up, is there anything else you'd like to add, sort of that we haven't spoken about already that's that you think might value add to sort of some of the things we've touched on today?
Yeah, I think that if someone is kind of a paramedic and they're looking at an opportunity to do something within primary care, I'm going to highly recommend it. I mean, obviously today, Duncan, we've gone over, you know, the challenges and the difficulties and kind of a bit of the hardship of entering a new role where, you know, you're suddenly not the solo senior clinician on scene anymore. And that is a little bit difficult to deal with at first, but if you like the job and you want, you know, exposure to all aspects of medicine, you can't ask for anything better. And, you know, seeing a patient on one day and seeing them for a follow-up in 2 weeks, and they're like, oh, I'm so thankful to you. You know, the medication that you gave me has really sorted me out. I had this issue for multiple months. It's really fulfilling and rewarding, and we often don't get that in the emergency kind of basis. We don't typically see people again. It's pretty rare. If we do, there's usually a specific reason for it, and they're probably not feeling better. But yeah, kind of getting to know your community and getting to know people and kind of the complexities of people and seeing them when they're very thankful to you, I think is super rewarding.
Yeah, unreal. Cool. All right. Well, thanks very much for joining me today with this. It's been really great. I'm sure our members and hopefully soon to be future members get as much out of it as the two of us did. And yeah, look, hang on, everyone. Luke and I will be live once this recording finishes, and you'll be able to ask him as many questions as you've written down during this. So again, thank you, Luke. And
no problem. I'll be sure to wear the same shirt.
Yeah. I'll have the same shirt as well. That way we'll look the same.
Yeah. Nice.
It looked like it's completely seamless. Not like we cut and pasted or anything like that.
Yeah. Thanks, Duncan.
No worries. Thank you. All right. Well, whoops.
Same shirt.
All right. So welcome back, everyone. We'll have Luke with us very shortly. I think he should be back.
Yep.
You there, Luke?
I am here.
Oh, there you are. Cool. Yeah, you're on a different screen to me. So what I'll do now is I'll somewhat make my little video disappear of my little head. I'll manage the chat, and if anyone has any questions, I can then fire them off to you, and then we can go from there. Or if you want to ask Luke a question directly, you should be able to unmute yourself. So just stick your hand up, and I can go through that that way as well. And it looks like we've got a taker already. So Andy, if you're still there, please fire away your question to Luke, mate. Oh, there we go. Try now, mate.
Thank you. That was actually an accident. I didn't mean to.
I'll put you on the spot, brother.
I didn't mean to actually put my hand up. But if I can work out how to turn my camera on, I'll turn on my camera so you can see my face. Oh, I can't turn it on. So, Luke, firstly, congratulations. You know, that's absolutely magnificent that you're doing primary care. I couldn't do paramedic practitioner, so I actually did a physician assistant program and then later got endorsed as a nurse practitioner. and I still remain as a registered practitioner. Registered paramedic. Just an inquiry from me. How do you find working with nurse practitioners? Is it fairly seamless? Is it a good part of the team? And do you work with physician associates also?
So great question. Working with nurse practitioners is definitely seamless. We have 3 in our current PCN who see kind of various conditions. They would probably see a quite similar patient load to myself, except I don't think they're prescribers yet. I think one of them is currently working on it, which is the only kind of significant difference. I don't work with any PAs here, but there are quite a few in primary care in the UK. And I think, yeah, PAs, nurse practitioners, physios, pharmacists, having this big group of people together, like as I said in the videos, is really interesting. And there's nothing like, a really complicated medicine question and having access to someone who has been a pharmacist, a senior pharmacist for about 10 years, and having a chat with them about, the pros and cons, or what do you think about this? It's really helpful as a resource.
And does that answer your question, Andy? And I've worked out how to turn your camera on after that too.
That's all right.
Nice.
No, that's good. Thank you. Especially when it was an accidental question.
It was a great one.
I was too quick. Yeah. Thanks for firing us off. Now, Jacinta's put one in the chat that I'll read out to you, Luke. It's, what are the costs for a patient and how is the role funded?
I think this is probably one of the most significant differences between the UK and Australia, is that there's no cost to the patient at any point. No one pays for any sort of GP practices appointments here. There's no bulk billing or private insurance. It's all on the NHS, which if you have a passport here, you're automatically entitled to, and if you are on some sort of visa here, you pay something called a immigration health surcharge when you kind of upgrade your 3-year visa or whichever type you're on. How is it funded is another interesting part about the role. So the NHS had decided to implement additional roles in primary care probably about 8 years ago now. It started with physiotherapists and pharmacists and nurse practitioners. And what they did is they basically fund the wage plus training costs to each of the PCNs who can claim that money through the NHS. So I wonder if that might be a bit of a challenge in Australia, where it's kind of less centralized, government-based, and more insurance-based or bulk bills and things like that. So yeah, the cost of the patient is zero, and it's funded directly by the NHS themselves.
Does that answer what you were sort of looking for, Jacinta? I've enabled your mic as well, if that helps. Alrighty. Another question is what in there. Do you need to hang on, I've run the wrong thing. Do you need to work for the NHS to prescribe, or is there private practice paramedic practitioners?
That's a good question. So you don't need to work for the NHS to prescribe, but what everyone typically tends to have here is indemnity insurance for yourself. So because I work for the NHS and work for a PCN, they cover my insurance costs. But there is private prescribing, which I've done a few times before. It's not my kind of primary role, but yeah, private prescribing exists and can be done only if you are an independent prescriber here. So there's a few different levels. There's kind of one where you work on a pre-arranged plan that's been signed off by a GP, and you kind of follow the directions on that. And then there's independent prescribing, which is kind of more autonomous.
Excellent. We've got another question here from Glenn. Do you have critical care paramedic practitioners working in primary care, or is that a separate role?
That's a separate role. So all the critical care paramedics that I know work for NHS trusts. So they are on road with ambulance services or in the HEMS services. There are some critical care paramedics who work within ITUs in specific hospital departments, but not within primary care themselves. I guess the kind of focus of work is quite significantly different.
Awesome. Hope that answers your question, Glenn. Pop another one in the chat or put your hand up if you want to use your mic. We've got another one here from Heidi. Is there an expectation to still work on road and maintain your ALS skills?
Good question. So most people who work within primary care as a paramedic practitioner in the UK work on something called a rotational role, which I realized I mentioned a few times in the video, but didn't actually explain what that is. So you essentially do 3 weeks within PCN, within primary care, and then you do 3 weeks on road for the ambulance service and kind of rotate like that. So the vast majority of people who have this role work in that capacity. They are expected to continue with their ALS skills and your kind of typical paramedic skills. For myself, no, my CPD focuses more on my relevant kind of workload within primary care. So I do keep up with my ALS specifically because it's only a few days per year. But other things that I probably would have done when I was in the actual ambulance service itself are omitted in lieu of kind of more relevant CPD to what I'm seeing on a daily basis.
Awesome. So we've got one here from Bev Archer. I might be able to answer this one because it's sort of semi-Australian based than UK based. So it's the question is pathway to paramedic practitioner defined in Australia? And if so, study requirements. I'm New Zealand based and this pathway is not available yet. So technically, Victoria is the only state that has a pathway defined, and they've recently had their Health Act changed and amended to achieve that. They're running their own paramedic practitioner program through Monash, using their own staff within Ambulance Victoria. So no external people outside of Ambulance Victoria were able to be part of that. So they're the only state really running with that actually as a title. External to there, you've got, and we're not affiliated with any of these locations either, this what's available. External to that, you've got Edith Cowan University over in WA. They run a a Masters of Paramedic Practitioner there as well. It's online with some intensive aspects. And they're the only two courses that are actually now running in Australia. There were a couple of others, they've since shut down. And the word on the street is there might be some more coming online in the next sort of 18 months to 2 years. So to answer your question, other than Victoria, they're the only ones with a defined paramedic practitioner role and the associated health changes of the Health Act that they can prescribe. Other states and territories run ECP or extended care paramedic programs, probably similar to what you have over in New Zealand. And it's sort of a variation of that throughout the different states and territories. So hopefully that answered your question, Jade. Happy to answer follow-ons from that as well. All right. So Jacinta's got a question for you again, Luke. What formal qualifications did you have to undertake to do this role?
Yep. So obviously a bachelor's first that I got in Melbourne, and then the entry requirements to kind of start the transition university course were that you had to be a fully qualified paramedic for 6 years. So then they put you in a grad diploma course. I did mine through Greenwich, and I've done my master's through CSU in Australia, and then my prescribing through Essex University. So in terms of what qualifications you need to have, a bachelor's, and then that kind of experience level, and then in the UK, the university course they put you through.
Excellent. Jade's got a question here. Given you're sort of pioneering the paramedic practitioner role, is there further scope and skill you'd like to eventually work towards expanding development of the role in the future?
That's a really good question. I think that probably developing this role in Australia or other countries in the future is going to be a really interesting thing. In terms of the actual skills within the UK, I feel like there's always room to kind of extend your knowledge in specific areas. I did a really interesting CPD kind of couple of days with some audiovestibular doctors and some neurologists recently, all about vertigo, and I felt like I was kind of all over managing vertigo and kind of assessing for red flags, and there was quite a few things that they taught me that I was unaware of. So I think rather than like one specific skill, I'm kind of focused on the moment at kind of building that kind of general overall knowledge up to provide better assessments for patients.
Awesome. Nothing better than being put back in your place when you think you know what you know already, is there? Like, oh, that's a bit humbling.
It's been happening to me over and over again, and I think it's really beneficial.
Yeah, it'll be the life of the role. It's a new role, and that's the only way it will evolve. We continue to learn. So that's cool. So,
yeah, thanks for the question, Jade.
Yeah, awesome question. Another question here from Glenn. What settings are available for practitioners? So he sort of listed like fast track, ED, GP, mental health wards, palliative care services. I know you did touch on some of that earlier. But yeah, so you able to expand on some of those areas?
Yeah, no worries. I think that covers off a significant amount of them. Obviously, primary care and the kind of majority of different hospital specialties and clinics have some ACPs to one degree or another. In the UK at the moment, the vast majority are probably nurse practitioner ACPs rather than paramedics. But there's also mental health kind of rapid response units that have paramedic practitioners on them. We have something in London Ambulance as well called extended response, or kind of like the enhanced care paramedics that you have in Australia, but they kind of go to roles where it looks like people won't have to be taken into hospital and kind of undertake a rapid response to make sure of that when there's uncertainty. They also have this really interesting chair when I worked for them that I'd never seen before. It's one of the ones that you kind of put under someone who's fallen and it automatically goes up like a robot. So they have a couple of extra skills and things that they can do as well. I thought that chair was really cool. But yeah, I think you've pretty much covered the majority of the settings that you'll find an average practitioner in.
Everyone loves the razor. Once you've used it, you wondered how you ever used it without ever using it. And even if you're a solo responder, you take it with you if you go to a fall. So
these were all solo responders. These cars.
Unreal. So core skills in the practitioner spells like ultrasound and other aspects like that. Is there expected core skills that you need to maintain? I think you sort of touched on that earlier when you spoke about CPD.
Yeah, exactly. I think that for me specifically, there's obviously a set of core skills that I'll need to maintain, but it'll also, because of the kind of settings that we mentioned before and how much they vary, it changes from setting to setting. So, I do X-ray interpretation, but I wouldn't say that I'm super confident about it, because we typically receive our reports from radiologists at the same time that we receive the imaging. So I think it depends what sort of setting you find yourself in, and kind of if you're getting a report from someone who does that, as a full-time job, it's probably going to be much more accurate than your interpretation. Core skills for me are kind of quite varied as well. I went a few days ago to like a child safeguarding course for a couple of days, which was really interesting. But yeah, I would say it kind of depends on the setting.
Yeah, excellent. So there's another question here from Jacinta about sort of a teaching series of practical primary skills would be great for people like yourself to share that knowledge. So watch this space, Jacinta. That's part of our sort of CPD development plans, along with what we're sort of doing with these webinars for this year, really starting to kick all that back into gear so we can really help the people working in this primary care space to get a bit of specific stuff around our scope of practice, and not just what we're doing here, but what other people are doing as well, because it might be something you'll be able to introduce where you are as well. So we've got another question here from Bob. Is there an equivalent organisation in the UK, i.e. like we have here, like our Paramedic Practitioner Institute? Is there an equivalent organisation like in the UK that can help paramedic practitioners sort of communicate and their voice being heard?
That's a good question. I think that it's probably more general than that. As the College of Paramedics and our kind of registration board, HCPC. But in terms of Paramedic Practitioner Institutes, it's quite niche still, and obviously it's quite niche, and since the role here is pretty new as well, and so I think that we'll see these things, just like our own institute, growing and providing those kind of educational sessions and CPD sessions and things like that quite significantly in the next few years.
Excellent. Well, that appears to be all the questions in the chat. Does anyone have any other burning questions they might like to ask Luke? I can enable your microphone if you'd rather talk instead of putting... Oh, hang on. Here's one just popped up. This is from Georgia. Did you need to complete a paramedic practitioner internship after your studies? Great question.
Yeah, I did. And that's part of the rotational role. So it's portfolio based. You have to have, the kind of classic things with any sort of internship or fellowship, like a log of hours and, case studies and reflections. And so you do need that as well as the kind of official university degree.
Excellent. Another question here from Glenn. Do you have to do night shifts?
So in the rotational role in London, at least, you don't have to do night shifts, because those 3 weeks with the ambulance services, you book your own shifts. You get a bit of a pay decrease if you don't do unsocial hours, but it's an option whether you want to do them or not. For myself personally, I work Monday to Thursday, and I do 10-hour shifts. So I do compressed hours with a 3-day weekend, which is just absolutely so significantly different to what we're kind of all used to with our rotas and late shifts and night shifts. And I'm a 4-day working week sort of person now.
Excellent. Yeah, no, I love that kind of work style too. Andy just popped in the chat too an update to the Victorian legislation, which is great. That you do not now need to be an employee of an ambulance service to be a paramedic practitioner in Victoria. The legislation specifies that paramedic practitioners must be approved by Department of Health. You're required to have a master's degree. Monash degree is now open to full fee paying students moving forward. And there's coming up in Australia, which we're part of, there's a paramedicine board with health ministers developing advanced paramedic practice endorsement in Sydney, which is coming up in April. And there's a few of us from our institute that are going down to that as a group. So thank you very much for that, Andrew. That was very much appreciated. Jacinta just had one other question from New Zealand. How long has the Paramedic Practitioner been in place in the UK now?
So officially, it's been in place for about 4 or 5 years in terms of, you know, the rotational role and a focus on primary care. There has been kind of unofficial paramedic practitioners for about 5 years before that, with kind of less clear kind of a need for qualifications and less clear need for, you know, what their training requirements were. But I mean, even that is, you know, about less than a decade. It's pretty fresh. And I think before that, you know, people kind of got qualifications in their own ways, but they've been around primary care for a much shorter amount of time than they've been around hospital settings.
Yeah, so nationally it says here, Andy must be from over that way, Andy Collin, nearly 2 decades in various forms. Yeah. So excellent. Thanks for that, Andy. Well, that appears to be all our questions. I want to thank everyone for joining us tonight. It's been great. This has been the first one we've run this year. There'll be more to come. Stay tuned to your inboxes, Facebook, LinkedIn, Twitter, and all that type of stuff. We'll make announcements coming up for the next one. So we'll pre-record another one this month, and that'll be released sort of a similar time, the end of March, for our second one for 2025. So once again, thank you everyone for participating. Luke, thank you for joining us from London. We're ending our day. You're starting your day. So Tuesday was pretty good. So at least you know it became nighttime. So you've got that to look forward to. And again, thanks everyone for joining us, and we look forward to catching up with you all at our next webinar. If you're not members, you're interested in becoming members, please jump on board from our website. It's www.acpp.net.au, and the membership registration form is available there. Thank you, everyone, and have a lovely evening. And for those that are in different time zones, have a lovely day. Bye for now.
I just saw I mentioned that it's 25 degrees there today. It's looking a bit